Now, Mobitz type 2, uh, second degree AV block. The causes can be, for example, pathological. It can be due to acute ischemia or chronic ischemia. And thus, who are those patients who have ongoing ischemia? Those who have on and off chest pain. For example, patients who have stable angina. They have something stable angina. They have something, for example, in the coronary arteries that can predispose them to this chronic ischemia. And what happens? Patients can eventually land up in block conditions. When they develop block, either they develop Mobitz type 1, for example, or type 2, that can in turn lead to chest pain. So, in both the scenarios, chest pain is the manifestation. Also, lightheadedness, syncope can be there, or hypotension, or altered mental status or cognition decline can be the manifestation. And in such scenarios, you do ECG and you will see either anginal manifestations on ECG or you do coronary angiography and you see there is evidence for this chronic ischemia. That needs to be ruled out. Also, if there are any cardiomyopathic features like sarcoidosis, there amyloidosis or Lyme's disease, that can lead to myocarditis. Or, for example, patients with hyperkalemia can undergo second Mobitz type 2 second degree AV block. Also, patients with endocarditis with abscess formation can also land up in this condition. This type of block, second Mobitz type 2 block, usually results from conduction system disease below the level of the AV node, so infranodal origin. If the prevalence is 20%, if it occurs in the bundle of his, and the rest of the percentage is when the Mobitz type 2 block occurs in bundle branch, like right or left bundle branch. So if the origin is left or right bundle branch for this Mobitz type 2, the prevalence is more. So patients who have blocks in their ECGs, for example, left bundle branch block, oblique right bundle branch block, or bifascicular trifascicular blocks, they will have obviously this chronic ischemia going on. Patients, since there is block, there is this abnormality in the bundle branches, and this may give rise to, because there is the pathology lying in the infranodal pathway, this surely is going to precipitate someday Mobitz type 2 or complete heart block. The medications like beta blockers, non-dihydropyridine, calcium channel blockers, digoxin, and certain antiarrhythmic drug history should be asked. Sometimes a young male, for example, male or female less than 60-year age, develops, for example, block. What is the possible etiology? He might be having this cardiomyopathy in the form of either amyloidosis or sarcoidosis, and sarcoidosis has been found out in 25 to 30% of the patients. Thus, such young patients with unexplained complete heart block should be evaluated for cardiac sarcoidosis. What is symptoms? As already described, pre-syncope, sudden cardiac arrest, chest pain, dizziness, or fatigue can be. Patients with Mobitz type 2 second degree AV block often present with bradycardia, but some may have normal sinus rhythm rate. When we do not, for example, do not feel any pulse in a patient, we do ECG. We do it because not just to pick this flat line on ECG, but we also sometimes there can be this heart block that we need to pick, because sometimes pulses can be feeble or in heart blocks. We don't know how long the pause will be there. We need to pick it because heart failures can in turn be precipitated or exacerbated by the development of heart blocks. And you may hear crackles on lung examination, elevated JVPs or peripheral edema can be. So, in nearly all cases, the diagnosis of Mobitz type 2 second degree AV block can be made in patient with irregular pulse. You will see irregular pulse and you immediately need to do ECG. This just could not be AFib. In AFib we get irregular pulse, but in blocks we can get irregular kind of type of pulse. And because there is a pattern 3:1, 4:1, 2:1. If there is 2:1 pattern, then it's difficult to judge whether this is Mobitz type 1 or type 2. For that we need 2-3 things as already described. PR interval greater than 200 or 300 and QRS narrow. Atropine if given and carotid sinus massage. Carotid sinus massage leads to conversion of 2:1 to high grade AV block, then it's definitely the disease pathology lies within this AV node or suprahesion kind of pathology is there, then it's Mobitz type 1. If it gets converted to 1:1 restoration to normal sinus rhythm, then it's high grade AV block and this is to be addressed. This is a severe condition. And if atropine is given, atropine can convert the 2:1 pattern to 3:1 pattern. That means improvement. More P waves are conducted now to the ventricles, then it is signifies or it is suggestive of Mobitz type 1 block or Van Kebak's type of block. You see, management depends upon the site of pathology. We know atropine will increase sinus rate, but the pathology here is infranodal. So atropine is not going to improve this condition. Atropine is generally avoided in patients with Mobitz type 2 AV block, although it is given in type 1 block. Rarely atropine or other agents can worsen infranodal block by increasing sinus rate without improving conduction. So how do we treat this condition? If the patient comes in hemodynamically unstable condition, then it should be urgently treated with beta adrenergic agonist, provided myocardial ischemia is absent, because otherwise you are going to increase the workload of the heart and patient is going more towards ischemic state. So what are those? These are isoproterenol, dopamine, dobutamine or epinephrine. And in most instances, if temporary this cardiac pacing with transcutaneous or transvenous pacing is to be done. Why do we use dopamine and why do we use dobutamine? Dopamine is to be used in hypotensive patients, but dobutamine patient is to be used in heart failure patients. That is patients having developed Mobitz type 2 heart block with hypotension. Here, Mobitz type 2, this heart block is developed with heart failure symptoms. For example, pedal edema, basal crepitations, like that. Patient that is, for example, patient has new onset left bundle branch block. Then in this case, patient is to be treated with dobutamine. Here, patient is to be treated with dopamine. Like in Mobitz type 1 block, if Mobitz type 2 block develops in the setting of this MI, then it should be treated with temporary pacing as well as revascularization, because following revascularization most conduction abnormalities will revert back to normal. Note that if no reversible causes are present, then definitive treatment of Mobitz type 2 block involves permanent pacemaker placement. And dual chamber, that is atrioventricular pacing to maintain AV synchrony, is preferred rather than single chamber, that is right ventricular pacing. Unlike asymptomatic patients with Mobitz type 1 who do not require any specific therapy, patients with type 2 have a high likelihood of progressing to symptomatic Mobitz type 2 second degree or complete heart block and should be considered candidates for pacemaker insertion on initial presentation. So Mobitz type 2 will either come in hemodynamically unstable or hemodynamically stable condition. These do not urgently require atropine therapy or temporary cardiac pacing, although it is by nature unstable and frequently it will progress to third degree. It should be continuously monitored with transcutaneous placing pads, or this patient should be a prospect for permanent pacemaker insertion. Whereas hemodynamic unstable patient, look out for the cause. If it is whatever the cause, first you have to give beta adrenergic agonist isoproterenol. You can give epinephrine, you can give dopamine or dobutamine. Dopamine is to be given in the state of hypotension, whereas dobutamine is to be given in the presence of heart failure. Before this, you have to look out for the reversible causes. For example, myocardial ischemia. If that is the cause, to revascularization therapy, because cardiac conduction abnormalities will get revert back to normal. Increased vagal tone is there, check out for that and treat it. Hypothyroidism is there, check out for that. Hypothyroidism is a reversible cause. Similarly, hyperkalemia is a reversible cause for Mobitz type 2. If you couldn't find any reversible etiology, then you should go for PPM.